Okay, we'll go ahead and get started. All right, so good morning, everyone. I wanted to welcome all of you to this year's annual Midwest Regional San Antonio Breast Cancer Symposium. This is our 11th year of offering this comprehensive review of the latest updates and therapeutic advances in the treatment of breast malignancies. So with a new format, I just wanted to go over a few housekeeping items. First, as we are using Zoom, you can find all of your webinar controls by hovering over the lower section of the Zoom screen. You'll be able to find your microphone, webcam, chat box options, among other things. So please make sure that your microphones are muted throughout the meeting. This is not the webinar option, so we will be able to hear you. If you need to ask questions, please use the chat box or wait until the Q&A portion of our meetings. You're welcome to also unmute yourself and ask the question directly to our presenters. And then we'll address all the questions at the end of the presentation. You can also send private messages to individual members if you have any questions. If you're having any technical difficulties, please close your browser, use the link to access the webinar once more. And then otherwise, send me a message via chat and we'll try to troubleshoot. The presentations are being recorded and they will be uploaded to our event website. We encourage the use of webcams, so in order to help create that face-to-face atmosphere during the meeting. And I wanted to remind you to use our virtual platform to visit our exhibitor booths. They've been working really hard to put up all the presentations and information that you need up there. You can chat with the company representatives live. Several of them also have included virtual chat rooms, and so you can see them via webcam. So make sure that you take advantage of that opportunity and thank them for their participation. Without their support, the Nebraska Oncology Society would not be able to carry out its mission of enhancing patient care through oncology research, education, and healthcare legislation. Continuing education credits are available for this event, 4.25 credits. So feel free to complete the evaluation on our event homepage to get your certificate. I'll also be emailing all registered attendees with the link so that they'll be able to do that afterwards. And with that, I'll turn it over to Dr. Mary Wells, who is our program chair for the event.
Hi, good morning, everybody. My name is Mary Wells. I'm a medical oncologist hematologist. Joined Nebraska Cancer Specialist here in Omaha this summer. And I'm really excited about our program today. I hope it's great. Our first topic today I know will be excellent, and our survivorship topic for this year is discussing oncofertility and fertility preservation, specifically in women with breast cancer. And I think as we have seen the gains we've seen in terms of being able to save more lives and more young women with breast cancer, this really becomes something we encounter very regularly. And I'm excited to get the most up-to-date information from Dr. Delaney on how we can help our women walk through this. So Dr. Delaney is a reproductive endocrinologist at Reproductive Health Specialists and an assistant clinical professor at Creighton University School of Medicine. She studied at the University of Nebraska Medical Center, where she completed her medical degree and residency program in obstetrics and gynecology. She continued training at the University of Louisville and the Mayo Clinic in the Division of REI. Dr. Delaney was recently recognized as Omaha's premier physician in 2020. And I can just tell you personally, she's an excellent resource in our community for oncofertility and reproductive endocrinology. So we're excited to hear what you have to say, Dr. Delaney.
Thanks, Mary. I appreciate it. Okay, I have to be completely honest with you. I am Zoom incoherent. I have not done many of these. So can I show my screen somehow? How do I do that?
Yes, Dr. Delaney, there should be a green share screen button if you hover over the bottom part of your screen. And if not, I also have your presentation. We can.
Well, why don't we just do it that way? Because I have no green button.
Yeah.
I was like Googling this before I got on, but
No
okay.
problem.
So, you know, nice to meet you all. You guys are clearly the experts in cancer, and I am here to talk about fertility preservation in the cancer patient. Particularly the special cases and considerations with regard to breast cancer. Thanks for the nice introduction, Mary. You know, certainly that was very kind. And I'm happy to give this discussion today, as it is certainly a passion of mine. And I feel like, particularly over the last 5 years out of fellowship, I've seen more and more cancer patients, and I want to continue to kind of drive this home that these patients can be mothers and you know, protect their fertility in the future. So we can go to the next slide. There's no disclosures. I am just a private practice doctor here in town. However, I do have an affiliation with Creighton. I will say that there is still one of the management options that I will discuss very briefly that are still classified as experimental at this time. That is ovarian cryo tissue preservation in a young patient and a pediatric cancer patient. Still should be at this time done under IRB protocol, but the remainder of my talk is all approved. Next slide. Objectives really are to understand the basic principles and science behind the practice of oncofertility. I really want to talk a little bit about just how to get patients in and like the actual timeline of things. I think that is the biggest concern, and forgive me if I'm wrong, but from I think an oncology standpoint is you have this patient that you want to cure their cancer, and clearly that is the ultimate goal, and you don't want to delay that treatment. And so I have some ideas and kind of just practical considerations when making that move forward. And then I would also like to discuss kind of the impact on fertility preservation on young breast cancer survivors. Some of the things that I see if patients don't come see me and then later on come back for fertility treatment, in addition to kind of when they show up in my office and how they feel and moving forward. And then we'll explore options. I'll talk about how things kind of work from the fertility standpoint in a little bit more depth. Next slide. So cancer is not, as you guys well know, a disease of the aging. So over 1.7 million people will be diagnosed with cancer. That was in 2018. From 2007 to 2011, 23% of those diagnosed were less than age 45, and particularly in women, those are kind of prime reproductive years. 54,000 Americans treated with cancer annually are at risk for subsequent fertility. And I think more important for today, 25% of new cases of breast cancer occur before menopause, and 7% of those are diagnosed before age 40. 21% of gynecological cancer patients are in their reproductive age and are yet to complete their childbearing. So next slide. So the most common cancers in women and men, this is based on just American Cancer Society. Clearly in women, it was breast, followed by lung, colon, uterine, and thyroid. And men, prostate, lung, colon, bladder, and melanoma. So clearly, you know, and I think breast cancer is always, I think, in every young woman's mind. Certainly, I think we all know someone, 1 out of 8 women that have been diagnosed with breast cancer. So, and I think from my perspective, these women want to feel like they have a life beyond their disease, and they want to feel like once they get their cancer under control, they can accomplish whatever dreams they have professionally and personally and emotionally in the future. As you guys well know, again, none of this is news to you, but 5-year survival rates are greater than 90% in these cancers. 72% of cancers in patients less than age 15 survive longer than 5 years. And there's certainly a decline in mortality rate and increase in disease-free survival of many cancers kind of over the last decades. So a lot of this data, next slide, started in about 2005. Now in 2005, I was a med student. But a lot of people started recognizing that at that time that, we weren't addressing kind of lifelong consequences of cancer as much as we'd hoped. And particularly, we weren't really addressing the fertility standpoint. And back then, the egg cryopreservation was still deemed experimental. And so a lot of, from like our field standpoint, we weren't doing a good enough job offering services to you guys. And so kind of over the last, 16 years, there's been dramatic increases in kind of what we can offer your patients and, how we can help people kind of survive and live on beyond cancer. So in 2005, about half of cancer survivors felt that their fertility concerns were adequately addressed. And subsequent studies have shown that that is improved, but not as much, I think, as we in reproductive endocrinology would like to believe. I think that, in my practice, I feel like I see plenty of patients for fertility preservation, but I also see a lot of patients that come to me post surviving cancer then with fertility concerns. And they always say, I just wish I would have known, or I wish I would have seen you before cancer. Personally, I have a family member who actually, my sister-in-law is a cancer survivor and underwent this exact problem. And she had cancer in her 20s, and unfortunately had to require donor eggs in order to have their second child. So, I think we as a reproductive endocrinology community can have a better chance of reaching out to you by giving presentations like this, offering our services, making sure that you guys understand that we will work with you to try to get these patients in and out as soon as possible so that they can start their treatment. And I think that all patients kind of deserve the opportunity at least to hear what we have to say and at least to understand that like there is an option for them should they wish to try. Next slide. So let's talk just organically, kind of objectively, cancer treatment and fertility. So, women are born with a finite number of primordial germ cells, and the reproductive lifespan is determined by this follicular pool. So, interesting fact, the most amount of eggs that women will ever have is actually in utero, right around 20 weeks. And the process of actually discarding eggs and basically kind of starting to utilize these eggs actually starts in utero. And at birth, that has gone from kind of 6 to 7 million to 1.2 million. And before we even start puberty, we again have kind of gone through this lifestyle process, and we, by puberty, there's only about 400,000. By menopause, women unfortunately only have about 400 or 500 eggs. And there's a ton of waste in kind of the female reproductive tract. When a fertility cycle starts, there's about 20 eggs sort of in cache, if you will. And the brain selects one, but the remainder of the 19 are just tossed. And so the bottom line is, our reproductive lifespan just sort of kind of makes the kind of fertility and cancer even harder. And it's because it's not like we can regenerate. Men, in contrast, they make new sperm about every 92 days. The sperm life cycle is about 92 days. And so they're constantly regenerating kind of sperm. And unfortunately, women, we do not have that. So in general, cancer therapy can result in subfertility or sterility, and it's due to kind of gonad removal. Sometimes we have to remove the ovaries, or permanent damage to the germ cells from that adjuvant therapy. Okay, so next slide. So again, this is not news to you, but cancer therapy targets rapidly dividing cells and metabolically active agents such as germ cells. So clearly, you guys know this, and it is used in breast cancer patients, but alkylating agents are the most threatening. For example, like cyclophosphamide, and they interrupt dividing cancer cells at the DNA level. They're not cycle-specific, and they damage both the germ cells and the supporting cells surrounding the germ cells. And so the problem that I sort of sometimes see is that I think, for example, like not necessarily in breast cancer, I feel like I get a lot of referrals for breast cancer, particularly if you guys know that you're going to use a alkylating agent. I feel like they're more likely to end up on my doorstep. But I think that there's sometimes there's a forgotten patient, those like Hodgkin's lymphoma patients, or the patients where you're like, well, your fertility should be fine, which if they're young, it should be. But if they're age 38, you are going to disrupt and damage a lot of those eggs. And by the time that they're out of cancer therapy, their ovarian age is going to be chronologically more like a 43, 44-year-old. And so their fertility is done. So yes, they may regain some of their menstrual function, but to actually create a child is going to be very difficult for those patients. Next slide. Alkylating agents are common therapy for many cancers, including breast cancer. So I always tell patients there's a 9 times increased risk in these patients of premature ovarian failure. The odds ratio of inducing complete ovarian failure with cyclophosphamide is 3.98 compared to those of unexposed patients. And there's just that cycle of follicular death. If you kill the germ cell, then you get this decreased estrogen and inhibin. And that basically signals, if you guys remember kind of the pathway, signals to the brain that FSH to sort of say, hey, oh my gosh, we're low in estrogen, like make more eggs. And that kind of causes more follicular recruitment. So instead of that 20 eggs that we start in a cycle, maybe there's 40 eggs. So you just continue to lose more and more eggs. So amenorrhea, which is, no periods, varies after chemotherapy. And it really depends, as you guys well know, on age and dose, as well as type of chemotherapy used. But the average rate of menopause in young women for any time of chemotherapy is 38 through 45. So we all know that these women go through menopause at a significantly younger age. The average age of menopause in women in general is 51. The bottom line is these patients, regardless of whether they're going to pursue fertility, are going to enter menopause at an earlier age. We'll talk a little bit, but both chemotherapy and radiation-induced germ cell is age dependent. Most cancer patients, if they're very young, like 21, 22, 23-year-olds, they're going to have a much favorable outcome with regard to their fertility lifespan than the patients that are 38 through 40 coming to see me. And the older that women get, they're just more susceptible to that permanent ovarian damage. In incidence of amenorrhea, so never regaining a period after a woman who's exposed to cyclophosphamide, methotrexate, and 5-fluorouracil is 61% in women less than age 40 and 95% in women age greater than 40. Okay, so what about radiation? Next slide. The ovary causes follicular disruption or the ovary is affected by radiation because it causes follicular disruption and is also dose dependent. It's age dependent, it's site dependent, and lethal dose of radiation required to kill about half of the primordial germ cells is less than 2 gray. The average treatment protocol for women who have any kind of radiation therapy to kind of their abdomen are 60 to 80 gray. So, I would say that probably this is ultimately ending up being kind of a more kind of fertility killer than sometimes the chemotherapy, and 20 to 40 gray in hematological cancers. The interesting thing, and I know this talk mostly is about breast cancer, but just for oncologists to understand, is that when you give radiation to the pelvis, we see on our end not only destruction of germ cells, but their uteruses don't respond in general as well. They have decreased implantation rates. They don't develop linings appropriately, and then subsequently obstetric outcomes are more difficult. There's an increased risk of preterm labor and preterm delivery in these women. They've had radiation, and so these are all things that if they're seen by a reproductive endocrinologist in advance prior to their therapy, you can sort of have a discussion and say, listen, like this is totally a possibility if you want to have a baby, but we want to make sure that you understand that these are the things that you'll face moving forward. Next slide. So childhood radiation actually also compromises growth and development of the uterus. I've done a couple cases in radiation cancer patients that ultimately, like, they had childhood cancer, they came back to me and we had to sort of quote unquote grow their uterus. And you can do that. You can do that with kind of sequential estrogen therapy, and sort of improve kind of their success rate moving on. But again, it's just sort of one of those things to sort of think about, that, you know, these kids, they've survived cancer, but then they have all these trouble kind of farther along in life. So we don't really know why radiation causes so much damage to kind of the uterus. We think it probably has something to do, obviously, with cell death, apoptosis, and then it also just, you know, it's devascularization. But that's probably what we're thinking. So oncofertility, again, like I said, was sort of born around 2005, 2006, and sort of has expanded the last decade. And the Oncofertility Consortium was actually started in Chicago at Northwestern. The new concept describes an integrative network of clinical resources that focus on developing methods to spare or restore reproductive function in patients diagnosed with cancer. Next slide. So again, the term was coined in 2006, and it sort of came about because we'd had at that point about 25 years, 30 years of infertility or IVF therapy. So IVF, just for you guys to understand that history, began in around 1971. You know, in that same year, there was a kind of war on cancer that was diagnosed. They established funding for National Cancer Institute at that time. And I will tell you that the reproductive endocrinology side of things, when that was diagnosed, we were hard at work trying to figure out kind of just how to make IVF work. This was sort of a kind of cerebral philosophy at that time. And so between 1971 and 1978 in Virginia, they were working very hard on trying to get IVF to work. And in 1978, Louise Brown was the first IVF baby that was born. And so between 1978 and now, there's been all of these advances. So my field in general, your field has been around for a long time. Cancer has been here forever, but my field has been only around really since like 1978. And during kind of the early part of time, we'll talk about kind of embryo versus egg cryopreservation, but there was a lot of kind of coordination, even back then, between oncologists and reproductive endocrinologists, trying to figure out, okay, well, we can cryopreserve embryos. What if we did eggs? If we did eggs, we could kind of help all of these cancer patients. What's a possibility? And actually, 1986, there was the first human pregnancy from a cryopreserved egg. Now, it was actually deemed an experimental therapy until 2009. So egg cryopreservation or oocyte cryopreservation really has only been around and available since 2009. So we have 11 years of data, good data, but we have 11 years of data demonstrating that it's a viable option, despite the fact that the first baby was born in the 80s. All right, next slide. So you guys know this, but I don't need, and I'm not going to belabor it, but oncofertility is supported by American Society of Clinical Oncology, NCCN, the American Society for Reproductive Medicine, which is my group that I follow, and ACOG. And ASRM still kind of classifies, so my group still classifies cryopreservation of ovarian tissue as experimental, but that the rest of it is a very viable option for your patients. Next slide. So again, this is no news to you, but the breast cancer patients and kind of what makes this group so difficult is that, you know, these are young premenopausal women that have a high chance of survival, but they're also high risk cancers. And there's concern regarding recurrence risks in these patients, and I'm giving them a whole bunch of hormones, and they're hormone receptors, and they're hormone sensitive. And so, you know, I think patients are worried. I don't think we are as worried as they are, but they are worried, oh my gosh, if I do something, is this going to cause my cancer to spread? Is this going to give me a higher chance of recurrence? What if I got pregnant? Is that going to cause a recurrence, et cetera? And, you know, I think those are all kind of things that I talk about at kind of the initial consultation. So next slide. So this was in 2009 when egg cryopreservation kind of it went from experimental to kind of not experimental. And what they found was that clearly, women particularly kind of that get cancer and breast cancer kind of have a higher chance of recurrence. More aggressive treatment, they require chemotherapy. And so because of that, we need to be starting to send people to reproductive endocrinology. So next slide. What they also looked at, and this was at Memorial Sloan Kettering, was that when we look at women post-chemotherapy, 85% of women aged less than 35 regain their menses. 25% of women aged 44 to 49 experience menopause, and the highest rate of amenorrhea, like we've already talked about, was with cyclophosphamide. Permanent amenorrhea and premature menopause were age dependent. And so what I want to focus on this slide is that when we say that 85% of women aged less than 35 regain menses, I want to sort of remind everybody that they can, you're right. But if a 33-year-old acts like a 40-year-old, and when they come to see me, they're going to have the fertility success rate of a 40-year-old. And so, I think there needs to be a shift in the oncology, kind of field. If we're talking about trying to preserve fertility, a lot of the fertility or a lot of the research on your guys' end is just regain of menses, whereas like we are like saying, okay, but regain of menses doesn't always equal pregnancy. So, while 85%, well, yeah, they'll get periods again, they'll cycle again. It doesn't always mean that they can have a baby. Okay, next slide. Oops. So women who regain menses after cytotoxic chemotherapy are likely to have undergone significant follicular depletion. So I tell patients that regardless of whether or not you've had cyclophosphamide or any kind of chemotherapy, I estimate and tell every patient that whatever age they start their chemotherapy at, that their ovaries are going to age 10 years. So if someone comes to you, they're diagnosed with breast cancer and they're 23, they will end chemotherapy and they will be 33, according to their eggs, which is great for those patients because at 33, they still have a very favorable outcome for having children. But what's not good is if they're 33, 34, 35, because when they end out of chemotherapy, their ovaries will essentially be in a range that requires donor eggs. So, typically I tell patients, I've had one pregnancy in the last 8 years and a woman over the age of 42. And so while they're young, they're so young. I'm young, I'm 40. They are not young and they're not kind of enough to carry a baby with their own eggs. And so I think that's sort of the important kind of thing for you guys to remember, and kind of a nice number for you guys to remember when you're talking to your patients is that, you may end up getting your periods back, you can certainly try for pregnancy, but just remember that, your ovaries are going to be acting significantly older. And so I think, for you guys, it's this balance, right, of being able to kind of protect the patient from cancer, but also dealing with, this potential kind of loss and grieving process for these patients that, we might lose our fertility. And I think we as reproductive endocrinologists, it's our job to sort of go through that and be like, here are the options. Sometimes it's just too much. Like sometimes what I say and they're like, they shut down and they're done. They're like, we're not going to pursue anything. We just have to focus on the cancer, which is 100% appropriate, but at least they've had the talk. Okay, next slide. So a lot of talk and I think a lot of concern. I've gotten a few questions from oncologists over the years. Do infertility treatments actually increase your risk of breast or ovarian cancer? So the National Institute of Child Health and Human Development did a multi-center case control study. 500 women with a history of invasive breast cancer versus 4,600 women with no breast cancer history. They did a questionnaire. Fertility drugs did not influence the development of breast cancer, except if they had greater than 6 cycles or months of therapy using HMG, which is human menopausal gonadotropin, so injectable medication. So if they did 6 cycles of fertility treatment at some point in their life, they had an increased risk. But so not in your patients. We're talking about going through like one cycle of IVF to cryopreserve eggs, okay? A follow-up study tracked all women, 24,000 women that were treated with IVF and delivered a child. And this was a kind of 1982 to 2006. And of 24,000, there was only 1,000 who had a diagnosis of cancer. And they actually showed that there was a decreased risk of breast cancer, which was more notable for women having pregnancy, that women who got pregnant actually had a more favorable outcome and did not develop breast cancer compared to women who were nulliparous, who never had a baby. Okay, so what about, next slide, ovarian cancer risk? So there was a Dutch cohort of 19,000 women, and it tracked the kind of incidence of ovarian malignancies. It did show a higher incidence of ovarian cancer and higher incidence of borderline ovarian tumors in the IVF group. The most recent study, which is 2010, which is kind of crappy, but there was a meta-analysis, and they basically show that there was no statistically significant association between increased risk of breast cancer, ovarian cancer, and infertility treatment. So the bottom line is, unfortunately, the data are conflicting with regard to ovarian cancer. I would say that we're pretty successful, like we're confident that it does not increase your risk of breast cancer, and in fact that fertility, particularly carrying a baby in the future, may be protective. But ovarian cancer, I tell patients that if we do many cycles, you are at slight increased risk of having a borderline malignancy, which is a pre-malignant tumor, not cancer. There is a slight risk, as there is with everything, and what is it worth it? And when they've surveyed, particularly breast cancer patients, this rate at all was a breast cancer. 89% of patients would like to proceed with some sort of fertility preservation. In 2004, there was a survey regarding fertility issues for women with history of early stage breast cancer. The average age of responders was 35. 60% of patients had been pregnant at least once before diagnosis. 73% were concerned regarding with future fertility. 30% indicated concern with fertility impacting their treatment, but only 17% were referred to a reproductive specialist. I think this is improved, but I think we can do better. All right, next slide. And you guys know this, that depression in breast cancer survivors is often related to reproductive concerns. These patients can benefit from a referral to reproductive endocrinologists to discuss their reproductive future, just to discuss family planning, discuss their options, and discussion to sort of like move forward with treatment really depends on a patient-to-patient basis. Not everybody has to do this, but at least they have the discussion, at least they know what they're facing. All right, next cycle. So what can we offer? I think this is sort of like, the most important thing and the biggest part of our talk. We can offer three things. We can offer GnRH agonist therapy, embryo cryopreservation, and egg cryopreservation. So I think that there's a lot of focus, and I think oncologists in general, your guys' field is doing way better at getting people Lupron and getting people GnRH agonist therapy. But I'm gonna put like a big stamp on it and just make sure that you guys understand that it's just not a cure-all. So in 2009, there was a prospective randomized study, breast cancer patients receiving adjuvant chemotherapy, GnRH agonist versus no GnRH agonist. And it was significantly lower. In the risk of premature ovarian failure was significantly lower in GnRH agonist co-treatment group. Now, again, remember that this is just resumption of menses after chemotherapy. This is not a fertility study. This is basically did these women gain periods again? And yeah, it improved the chances that they were going to regain cyclicity. There's been, since then, that was kind of the first study in 2009. There's been 3 other prospective randomized trials. None were adequately powered. And there was an independent meta-analysis that shows a trend towards maintaining ovarian function post-treatment. So I think that you can tell your patients 100% that if we give you Lupron, it's not going to it's not going to be like a cure-all for your fertility, but it should maintain your menstrual function, and that like you should have an improvement in the chances that you won't be menopausal after chemotherapy. So it's, like I said, menses may resume after chemotherapy, but data on fertility potential is lacking. And I will tell you that, I struggle with this, and it kind of depends on age. And it also depends on how sick the patient is. I mean, if they're 39 and they're hospitalized and they need chemotherapy right away, there's no time for anything else. We don't have time to cryopreserve eggs. We don't have time to cryopreserve embryos. And so Lupron is the best we can do for those patients, but patients need to sort of understand that while that may kind of preserve their ovaries, I don't think necessarily it equals a baby in the end. Next slide. So I generally tell every patient that like Lupron is an option for you if you say that you want to come out of chemotherapy and you don't want to be menopausal. Like you want to do everything in your power to make sure that you're not menopausal. And I contrast that with the alternative is if you want to come out and have the very best chance of having a baby, these are your other two options. So let's talk about those. Embryo cryopreservation. So that has been around for the longest period of time. Remember, I said that egg cryopreservation really only lost its experimental model in like 2009. Clearly, it requires a partner or it requires donor sperm. And success rate has dramatically increased. Generally speaking, age less than 35, they cryopreserve embryos. I tell them that per embryo transfer, they have a 50 to 55% chance of a take-home baby. 37 to 39, it's about 48 through 50, and age greater than 40, it's about 40 to 45%. And cumulative success rates, again, your hope with these cycles is always to get more than one embryo, is greater than 60% if you have several embryos available. All right, next slide. Egg cryopreservation. It's ideal for women who don't have a partner and who really are like still hoping that they can find a partner in the future and eventually fertilize those eggs with sperm. They still have to undergo ovarian stimulation and egg retrieval. I recently was pointed to watch an episode of Grey's Anatomy. I don't know we all laugh at Grey's Anatomy, but Izzy got cancer. She had melanoma, and they just randomly called an OBGYN who like somehow went in there, grabbed some ovarian tissue and like fertilized eggs, which I thought was really funny. That's not how this works. But generally speaking, the patient still has to undergo ovarian stimulation and egg retrieval, and it is a numbers game. The more eggs that we retrieve from them, the more opportunities for future fertility. Next slide. So Brigham, when I was actually in fellowship, so this was probably around 2015, developed an egg cryopreservation tool. And you guys can use this and basically go in and you kind of put in the patient's age. And if you have a little bit of data from me, and you can tell them kind of what their chances are of having a baby in the future based on the number of eggs that we retrieved. The difference between eggs and embryos is that eggs don't freeze as well. They're fragile. And so when we talk about kind of frozen embryos, 99% of those come out of the freezer and they're very successful. And freezing doesn't sort of harm eggs. There's a new freezing protocol that we've developed over the last 10 years called vitrification, which really helps doing that. But cryopreservation of eggs, only about 85% survive the thaw. And so there's attrition. And unfortunately, that's why egg cryopreservation is not as successful. It's still a great option for patients, but it's just not as successful with embryos. So I generally tell women, and I have really hard conversations like with women that are aged like 37 through 40, I say like, listen, we need to be really serious here. And if you really want to have a baby, we need to fertilize with donor sperm if they're single. Okay, next slide. So let's talk about like outcomes, like do these babies do well? So in 2009, this sort of actually switched from an experimental therapy to an actual therapy. And there was 936 babies born from cryopreservation of eggs. At that time, it was around a 35% success rate per cycle. I would say that with cryopreservation of eggs, that's dramatically increased over the last 10 years. It's probably about 40%, like 45%. It's probably gone up quite a bit. You know, I tell everybody that if you're trying to get pregnant, whether or not you are doing IVF or whether or not you're doing it the old fashioned way, there's about a 3% chance of having a baby born with a birth defect. And it was not different in any of these women who had babies born kind of via IVF and oocyte cryopreservation. The most common birth defect was a ventricular septal defect, a cardiac evaluation. And we tell every patient that is in general, just with IVF process in general, that they need to have a fetal cardiac echo because of slight increased risk of cardiac defects in IVF in general. IVF in general has always been linked to epigenetic syndromes, but in particular with the egg cryopreservation, this doesn't seem to be a problem. Next slide. So how does this process work? General IVF process, stimulation is initiated within 2 to 3 days of a menstrual cycle. If they're on birth control pills, this is easy. We just stop the birth control pills and then we start initiation of treatment 5 days later. If they're not on birth control pills and they're several weeks out from a menstrual cycle, it's still okay. We're not going to delay treatment for you guys. We can use GnRH antagonists, which is another medication that we just basically knock down wherever they are in their cycle, and we facilitate treatment. And patients with like PCOS who really never cycle, they can generally just go straight into treatment. We utilize medications that are synthetic FSH, so follicle stimulating hormone, and they're daily subcutaneous injections. Next slide. Typically, the stimulation process for IVF takes about 10 to 12 days. So on the left here, this is a picture of what an ovary looks like pre-stimulation, and on the right is a picture post-stimulation. And during the period of time when they're stimulating, they see us frequently. Generally speaking, they see us every 2 to 3 days. And we're looking for a certain size with regard to follicles. Usually when they're about 18 to 20, we can give a final trigger shot, and then 36 hours later, they have an egg retrieval. Next slide. So this is what an egg retrieval kind of looks like. You can see on the left side, that's a vaginal ultrasound probe, and ultimately that is attached to a needle. And we go in there and we basically aspirate out all of those eggs. The right-hand side is kind of what the eggs, a mature egg, would look like under the microscope. And, you know, it's a very kind of easy procedure. I don't ever send anybody home with like narcotics. Most people tolerate this very, very well. Next slide. If they're doing egg cryopreservation, the egg cryopreservation is done that day, and they're done with treatment. Most of the time, once they're done with treatment, like 3 or 4 days later, they start chemotherapy with you. If embryos are being preserved, they are actually grown out in a dish after ICSI, which is what this picture is, intracytoplasmic sperm injection. Once they reach a blastocyst stage, which is an embryo that's capable of freezing and capable of having a future pregnancy, they are cryopreserved. Next slide. So this looks at kind of what a blastocyst looks like. And we now also can offer pre-implantation genetic testing on these embryos. You can either do it for PGTA, which is for aneuploidy, and that's to check just 46XX girl, 46XY boy, or we can also do it for pre-PGTM, and that's for like BRC1, 2, Lynch syndrome variants, etc. What's kind of important for you guys to know is that it's helpful for us if they've had their genetic consultation prior to seeing us. Because if they know that they're PGTM, what we can do is we can contact our genetics company and immediately start the leg workup. The creation of a probe to do pre-implantation genetic diagnosis for monogenic disorders takes about 6 to 8 weeks. So what we do, it doesn't delay your patient's treatment at all, but what we do is we biopsy the embryos and then we just sit on them. We wait for the probe to be developed, and then once the probe is developed, then we send them to the company. So again, it doesn't delay anything at all, but if patients are desiring PGTM, they won't have the results of everything until kind of much later in their treatment. All right, next slide. So they come back 2-3 years later. You know, I know in most breast cancer patients, the recommendation is at least 2 years post-therapy, and we can transfer an embryo. The preparation for this process is significantly easier. Generally speaking, it's just some oral medication to thicken the uterine lining, and we can transfer the embryo right back in. The pregnancy test is 8 days later. Again, people kind of tolerate this very, very well. Next slide. So there is something special that I do in my cancer patients to kind of prevent high levels of estrogen during this therapy, because the point in IVF is to create as many eggs as you safely can. And as you create those eggs make estrogen. It is not unreasonable to see levels as high as 3,000 to 5,000 picograms per milliliter in women's undergoing IVF. But when you use letrozole, you can actually decrease that estrogen level by like 3/4. And so my goal with these cycles is always to minimize elevation of estrogen, shorten the course of controlled ovarian hyperstimulation, and then maximize the number of eggs that these women are getting. Next slide. Just one slide just on cryopreservation of ovarian tissue. So this is the only cryopreservation therapy or fertility preservation therapy that we have in premenarchal girls, is to cryopreserve ovarian tissue. Most of the studies are done overseas. Most of the studies are done in the Netherlands. There's really one clinic that does the majority of these. And what they're able to do is they take out the embryo, or they take out the ovary, and they harvest ovarian tissue. They freeze that ovarian tissue, and they actually implant ovarian tissue. They can either implant it back in the pelvis, they can implant it on like the forearm, they can implant it in the subcutaneous tissue of the belly, and they undergo a similar IVF process much later on once they have kind of reached like menarche. There, as of now, there's been about 13 healthy babies that have been born via transplanted frozen throughout ovarian tissue. We had, when I was at Mayo, we had several patients that were kind of undergoing were undergoing freezing of tissue. But it's not very big in the States. And there's always risk because you're removing entire tissue, and are you putting cancer back in? And, generally not breast cancer, but, some of the hematological malignancies can metastasize to the ovary. And so you always sort of worry about that. Okay, next slide. This is kind of from the American Society for Reproductive Medicine, which is sort of my governing organization. And it talks a lot about kind of how we should proceed with regard to offering these patients fertility preservation. So you can see like newly diagnosed breast cancer consultation, and, basically they're referred to us, and we talk about really emergency ovarian stimulation. We talk about GnRH agonists, or we talk about alternatives, like if they're too overwhelmed and they're not interested in any kind of fertility preservation, what does it look like to do kind of egg cryopreservation, embryo cryopreservation? What does it look like to have a surrogate in the future if they're removing their ovaries, or if they're having high dose radiation and I can't get their uterus to respond in the future? So these are all kind of things that I talk about at kind of an initial consult. Okay, next slide. Cost. So unfortunately, Nebraska, now some of you are from kind of all over the nation. There's a lot of states that have mandated coverage for women who are either undergoing IVF or for women who are undergoing cancer therapy for fertility preservation. Unfortunately, in Nebraska, that's not the case. And so these are kind of estimated costs with regard to kind of oocyte cryopreservation or embryo cryopreservation. So our clinic offers a Live Strong discount. Lance Armstrong ultimately ended up being kind of a jerk, but he did something really Livestrong Foundation, which provides really low cost fertility treatments. And so it does end up egg cryopreservation. If we're able to get a Livestrong discount, ends up being right around 5,000. Embryo cryopreservation is generally around 7,000. And then future embryo transfers are also discounted to about 5,000. What's interesting about Livestrong is they're going through some restructuring right now. We don't have the final statistics right now, but in the past, they've always paid for all the patient's medications. And a lot of IVF, these medications can be incredibly expensive. I generally estimate patients around $5,000 per cycle. And so it was huge to get these medicines paid for these patients. But it sounds like they're not going to be offering full kind of coverage, but like also a major discount that, in the future. So I generally am probably going to be upping these prices, unfortunately, as Livestrong sort of restructures. We've reached out to a couple other companies. There's a few other companies that do some fertility preservation, and we're working with them to try to figure out kind of what they can offer for patients. Next cycle. Just a couple slides just on safety of pregnancy after breast cancer. I think, again, we're not as concerned about this as I think our patients are. But most studies show that pregnancy is actually protective against a recurrence. So, you know, the bottom line is it's very reasonable for these women to continue on pregnancies. Again, these are research, next slide, these are resources for women per programs that offer financial assistance. And most REI clinics across the nation will help facilitate these resources for these patients. They do not need to seek these out. They're going through enough. So we have an entire kind of billing department that helps manage these patients. And so we work with them really, really closely. Next slide. Okay, these are kind of just the conclusion slides. Clearly, we know that completing all chemotherapy is important for survival. Decreased risk if women wait until 2 years after a diagnosis or longer. And given the need to wait to increase breast cancer survival, that is something that I think a lot of patients don't understand, that, you know, if you're waiting 2 years, that actually is going to decrease your fertility rate even. So even if they're not using an alkylating agent, even if you're not using something that you think is going to be detrimental to their ovarian reserve, if they come to you at age 35, their ovaries age 10 years because of treatment, and then they have to wait 2 years before they try to get pregnant, they're in the donor egg category. You know, I won't be able to utilize their eggs. And so I think, you know, I think the biggest thing is just we, you know, most reproductive endocrinology clinics, I know we try to get them in within like 48 hours. You know, you guys call us, we fit them in wherever we can. And, you know, everywhere I've worked, that's been similar. So when I was, you know, here, Louisville, and at Mayo, you know, certainly Mayo had a lot more infrastructure to make this happen. But, you know, our goal is to just get them in as soon as possible and get them started. And it shouldn't really delay things more than kind of 2 to 3 weeks. So in conclusion, next slide, you guys know cancer is not a disease of just the aging, because you guys are so awesome and, you know, curing people and they're living on their lives. And so, you know, it's our job to sort of help them on the other side of cancer kind of accomplish their fertility goals. Next slide. You know, young breast cancer patients I know are kind of higher risk cancers and generally require chemotherapy, which unfortunately causes problems for future fertility. We do everything in our power from a reproductive endocrinology standpoint to decrease their chance of, you know, progression of cancer by utilizing letrozole. And there's no evidence or risk of breast cancer with controlled ovarian hyperstimulation. And then there's no incidence of increased breast cancer risk with pregnancy after survival. And then final slide, I tell everybody that the standard of care is embryo cryopreservation, but we talk about all kinds of options when patients see me, and that, you know, their future is unlimited if they decide to proceed with therapy. at that point, I'll take some questions if you guys have anything.
Dr. Delaney, thank you for the talk. That was awesome. I learned a ton. Anybody who has questions, go ahead and enter them into the chat box and we'll read them off. In the meantime, I have a couple questions. So women who are going to be on 5 years of adjuvant endocrine therapy, a lot of these younger women, that's a ovarian suppression, letrozole, tamoxifen, can they be on those and undergo embryo transfer and be pregnant while they're on those medications?
Yeah. So they'd have to be off of them.
Okay, so they'd have to get to 5 years out by the time they did their, okay. Oh, so you were talking about letrozole use. Is that during, I wasn't clear about where in the process you're
So I use letrozole usually starting kind of 2 to 3 days before I start the gonadotropins. I start letrozole to just decrease just the aromatase, like the aromatase antagonist, like it just basically decreases estrogen levels. So I'll continue that through kind of their entire ovarian stimulation cycle and then stop it once they get their period after the retrieval. And by that time, you know, a lot of times we combine therapies so that if they're doing embryo cryopreservation, like we also give them the antagonist as soon as they're done after cryopreservation of eggs. So a lot of times when they're asleep for the egg retrieval, we give them their Lupron shot, and that way we've covered 2 bases. We're doing everything we can to kind of try to preserve their fertility.
Any other questions, either in the chat box or you can just unmute yourself and ask a question. All right. Well, I think our time's about up anyway. Dr. Delaney, thank you so much. That was
Thank you.
fun.
Awesome. Thanks, guys. Nice to meet you all.
Thank you, Dr. Delaney.